Yes, sir, you can start now. Yes, sir, you can start now.
Yes. Good evening, everyone who is joining from Southeast Asia. Me, Dr. Bansi Sabu, as a chair of International Diabetic Federation Southeast Asia region. I welcome you all. And particularly, I am thankful to Dr. Barbara, not Dr. Barbara, Miss Barbara. She is joining from Chicago. She is currently based in US. She is actively engaged with American Diabetic Association activities. We have with us Dr. Manilka, who is currently chair-elect of International Diabetic Federation. We have with us Dr. Madhu Pandey from Nepal, as this is the program of IDF Southeast Asia, and on the eve of World Health Day. Now, why we are doing this program? One, we have tried to create a program where we are inviting all the female diabetologists, endocrinologists, and metabolic physicians of Southeast Asia to join for this. We want to empower all our female physicians, all metabolic physicians who are female and working in the area of diabetes and metabolism in Southeast Asia region. And we want to empower them in every aspect. We want them to be part of actively engaged in our International Diabetic Federation activities. So me and Manilka, we decided that we will have more and more female partner in our IDF Southeast Asia organizational activities. With these few words, once again, I am thanking both the speakers and I request Dr. Rutul and Dr. Manilka for further proceedings. Over to Dr. Manilka and Dr. Rutul. Thank you.
So yes, Dr. Manilka is the first chairperson, so I'll request him to introduce Barbara and we'll start the session. Thank
Yes.
you.
Thank you very much, Banshi, and thank you for the initiative. I think it's a very good move, and we should do more of these things in our region, which will be useful for all the countries, including Sri Lanka. So it's my pleasure to introduce Ms. Barbara Icos. I hope I got the surname correct. I was trying to pronounce it. MSRD CDCES is a clinician, global cardiometabolic health expert, and vice president at the American Diabetes Association. She leads programs that translate the latest science into practical team-based care to improve the lives of the people living with diabetes and obesity. I think it's a pleasure to meet you, Barbara, and then it will be very interesting for our audiences to listen to you. So it's my pleasure to invite you to go ahead with your speech on holistic lifestyle management for cardiometabolic health. Over to you, Barbara.
Thank you.
Is this the time that I'm presenting my presentation, or this is the introduction only?
Yeah, this was the introduction only. You can share your presentation. Yeah.
Yes.
Thank
I
you.
think
And
just before the next presentation, we'll introduce the next speaker, isn't it? Rutul can introduce the next speaker.
Yeah. Yes.
sounds good. Just want to make sure that my presentation is visible for everybody.
Yes.
Yes.
If you can put it to the presentation. Yeah, good.
Thank you. And thank you so much for inviting me. It's a complete pleasure to be speaking to the Southeast clinicians and talking about a topic that is very dear to my heart because I'm a woman, so holistic lifestyle management for metabolic health. I am a dietitian by training and have worked with both women and men in helping people to live the best lives within a metabolic health. The objectives for this 15 minutes to 20 minutes maximum presentation is to define metabolic health with the context of cardiometabolic disease and the whole person care, and identified evidence-based strategies to optimize metabolic health across the life cycle, the whole thing, clinical and behavioral domains. And finally, apply a system-based approach to designing effective person-centered metabolic health within the different healthcare systems or clinical settings. So globally, cardiovascular disease or cardiometabolic disease is the #1 cause of a death in women globally, accounting for about 35% of all female deaths. As you all know about diabetes, over 2 million women worldwide are living with diabetes or pre-diabetes. 1 in 3 women globally is affected by obesity or overweight, which is a major driver of metabolic dysfunctions. And more than 60% of women have at least one metabolic risk factor, such as hypertension, dyslipidemia, or insulin resistance. And of course, gestational diabetes affects 1 in 6 pregnancies globally, which is a risk factor for type 2 diabetes or cardiovascular. And overall, we know that it is linked to or shaped by biology, environment, and access to care. At American Diabetes Association, we look at it always from a perspective of patient-centered intervention. So anything that we design is not just about one behavior, but all of the behaviors that are contributing to the metabolic health. So whenever we think about it, it's always that person in mind, which we call person-centered wellness and intervention. So with that, we have the holistic approach where we look at the pathophysiology, understanding how the medical condition works in the body, what is the biology, and how it shapes the possible behaviors and how we can modify those behaviors to achieve those clinical care outcomes. We are looking at the readiness to change, which I'll talk a little bit more about in a few minutes. But we're also looking at healthy eating, physical activity, medication use, monitoring, reduction of acute risk factors, as well as chronic risk factors management, problem solving, and overall helping people to figure out what to do on a daily basis. So disease management, being a dietitian, is to sit with the patient and just identify what is the hardest thing for you right now and what can we do today to make your life with diabetes or cardiometabolic better today. So it's always about changing those daily behaviors that with time it's going to add up and then improve the people's health outcomes. Another interesting way of looking at it is from a nutrition perspective, is that 7 out of the 10 new cases of type 2 diabetes are caused or directly impacted by nutrition. So nutrition is typically the reason that people would be identifying as #1 thing I need to change. And it happens to be probably the hardest thing to change with metabolic health, because nutrition is who we are. It's our culture, it's our family, it's our psychology. So it is not an easy thing to modify, especially when it comes from when it's connected so deeply to people's personalities and their culture. We have evidence indicating which nutrition patterns are positively impacting metabolic health in the forms of disease management, A1C, triglycerides, cardiovascular outcomes, weight, LDL, blood pressure, HDL. And then out of these specific patterns, there is 7 that is identified, and this comes from the consensus statement from 2019. And this year, 2026, we're going to have a new consensus statement, nutrition consensus for prevention and management of diabetes coming out. So that could be a new evidence, but I'm still using what has been published in 2019. And you can see that there is the patterns that are producing positive clinical outcomes are Mediterranean, vegetarian, vegan, low fat, very low fat, low carbohydrate, very low carbohydrate, DASH, which stands for dietary approaches to stop hypertension, and paleo. And then within all of it, it seems that most of them can lower weight. And it's obviously, anytime we reduce calories, the weight loss typically happens. But you can see the Mediterranean is the one that is consistently showing the improvement in a strong metabolic health outcomes. And then, of course, we're looking at fasting, intermittent fasting. There is new evidence that hopefully with 2026 consensus, we're going to have more evidence to indicate that intermittent fasting is producing, it's good for our body. So when you think about what are those specific meal patterns. So vegetarian is to avoid all flesh foods, but include eggs or dairy products. Vegan, avoid all flesh foods and animal derived products. Sometimes we call it fresh foods. And then low fat is less than 30% or equal to 30% of total calories, and with less than 10% of saturated fat, and emphasizes vegetables, fruits, starches, lean protein sources, and low-fat dairy. Very low fat, it's 70 to 75% carb, and then 13% to 20% protein and 10% fat. And there's a distinction between low carb versus very low carb for cardiometabolic health. And low carb is 26 to 45% calories coming from carbohydrates versus very low carb is less than 26%. So you can see that the distribution of low carb versus very low carb, there is almost identical indication of the cardiometabolic markers. Both of them work very well. So let's talk a little bit more about finding a perfect fit. And we know that one fit does not fit all. That's why there is typically no specific formula, because our biology is different, our environment is different, and it's just too many different variables to figure out what's good for one patient versus another. So we really need to individualize and rely on patients' preferences, and then their existing environment, where they live, what they have access to, and then go from that, instead of providing specific formula that this is how it's going to work. So the best way to approach food is to, or nutrition is the best outcomes. It happens when we individualized. Every single person is different. And then there's no ideal percentage of calories from carbohydrate to protein and fat. And when it comes to thinking about it from a perspective, one single recommended nutrition plan for everyone, it isn't one. I remember when I started to be a dietitian like 30 years ago, it was 1,800 calorie diet or 1,200 calorie diet, and it was 88 diet, and it was going through, and we were to go and educate the people on that. And it was, and patients were coming back, and then they're like, I tried it, it doesn't, it doesn't work. And people really try to follow those things, but especially those calorie restrictions are really tough on the body and our metabolism. And it's not really about the calories, it's really about the food, what people eat, the density of food, joy of eating. It's a lot of psychological stuff that come with how people eat and what they eat. So it needs to be really individualized, and a person living with diabetes needs to work with clinicians on a regular basis. And we always partner with physicians in that journey where we are consistent with storytelling and supporting people on the journey. And it takes years, and then people get to their goal, and then then life happens, and they get their A1Cs, blood pressure changes because they get older, their metabolism changes. So it's really an ongoing process with changing the medications, the lifestyle, and so on. So when it comes to nutrition, emphasize non-starchy vegetables, minimize added sugars and refined grains, and choose whole foods over highly processed foods. And this is very consistent with the here in US, we have a national guidelines for healthy adults that kind of in the past it used to be like a plate and eat of the half of a plate with non-starchy vegetables, a quarter of a plate protein, and a quarter of a plate starches. Now we got back our pyramid. But it's upside down, showing that the pyramid on the top should be the vegetables and then non-starchy vegetables. But they emphasize for healthy adults, they emphasize whole foods. Like eat a real potato, read a real apple instead of juice, real starches instead of a processed food, and meat, real meat instead of processed meats. So it's kind of the more whole, holistic approach is the way to go. And then I've always used this for people to understand that biology, like when I was showing you those 9 domains, like what's important with metabolic health, it's important for people to understand how their body works and how it's being processed. So then like they can visualize the reasoning for why we're making those recommendations. And I'm sure you have seen this a million times, but it's still that understanding that carbohydrates are the ones that turn into the blood glucose most. The body needs to produce the most amount of insulin in the body, then insulin is the one that circulates. It is going to produce more hunger. It is going to be like if we only eat carbohydrates, we're going to end up being hungry on a regular basis. So it is important to add the protein. Wherever we eat carbohydrates, we want to make sure that we also eat protein and we eat that fat, because it kind of slows down the absorption of carbohydrates, and then it doesn't increase the blood glucose very quickly. So it's important to understand the logic behind the biology and how things are being processed. And when it comes to blood glucose, we know that food is not the only one that impacts the blood glucose. Medication can do that, activity. Many times people would exercise and then it would be like, oh, how come my blood glucose goes up when I'm exercising? And have those questions. Biological, and you know why now with the big thing is sleep. Sleep made it to our standards of care, stress, recent hypoglycemia. So there's so many different things that can impact blood glucose, environmental, and of course behavioral, that people develop a different coping mechanism that kind of often goes against the biology, and they have to really figure out what's going on in their life. When it comes to disordered eating, it is fairly common. And I notice that I'm not saying eating disorders, but disordered eating, because disordered eating is different spectrum. People have different relationship with food that could be unhealthy and can contribute to unhealthy behaviors that lead to poor cardiometabolic outcomes. But 18 to 40% of people living with diabetes have disordered eating, which is pretty frequent, and that's what we know about. There's evidence, but I'm sure there is more. So when it comes to let's say behavior change, and then this is just an example of the food and healthy eating. So imagine the same behaviors would be applicable to sleeping, to physical activity, to medication taking, a lot of behaviors. It is very difficult to change how we function, and not because of a lack of education, because we tell people, you know, what to do, how to do it. We can give them the script, do this at this time and this time. But it's because we are predisposed to repeated behaviors based on our immediate physical, social, and emotional consequences. So we have different cues on a daily basis that drive our behavior, and then it creates like a routine that our brain gets used to it, and then the reward that comes with it. So the whole psychological aspect of change of developing a behavior that we are asking people to change, it just doesn't happen that way. It just takes time to to correct one behavior that leads to this one, and then we add another behavior. So a lot of work. But what the good news is, once people start doing one healthy behavior, then they're more likely to do another one. And like I will tell you, as a dietitian, I rarely talk about food with my patients at the first visit. Very rarely. I don't even want to start with food, because if I start with food, they're going to feel overwhelmed, and then they'll not come back. I would focus on what's important to them and what they can do. And oftentimes I would ask, what's important to you? What can you do till the next time I see you to feel better? And they'll be like, well, maybe I can walk every day. And then we talk about walking every day, and I see them 1 week after, and we talk about how good it feels to walk every day, and they already feel good about themselves. So then maybe we can talk about food. But we want to start with something which is easiest, because then people have the reward aspect. I feel so good because it wasn't that difficult. I already feel better. I got myself new shoes. I look better. I bought, let's say, fancy exercise clothes. I feel like I'm a superstar, and people then are able to add, maybe I'm going to eat breakfast. So that you build on that healthy behavior, and you celebrate that healthy behavior and continue to grow it. And that is also the way that we want to approach nutrition. So mindful eating is really the way to go about it, where people pay attention to what they eat. They would literally start thinking about what they're eating. And a lot of times people who live with overweight or obesity, they eat very quickly. They don't pay attention to the pleasure of eating. They might be eating alone, watching TV or TikTok, and not necessarily with the family, having a conversation, and then a part of a social environment where we are meant to be. We are social humans. We interact with others, and that like simple things of eating create a lot of pleasure. So we really want to go back to allowing people to know what they're eating and have a pleasure of eating, because once that happens, they can establish a better relationship with food and better routine that eventually can change with time. When it comes to the behavior change, another thing to keep in mind is stages of change. People don't change. We often say people are in denial, and then even though if they're in denial, like they're in pre-contemplation stage, like I really don't want to. They might be in denial that they have a medical condition. Sometimes they may be in denial that they have somehow contributed to it, or in denial that they have a power to change it. Regardless what it is, when they tell us like, I'm not really ready to lose weight. Like I've tried so many times. I'm like, it's not my fault, and all of the reasons that they're going to state that they cannot do this. There's still a good patient, and we can still do something about it. And really, when they're in that stage of pre-contemplation, it is good to explore their feelings and ask, tell me more. How do you feel about that food? How do you feel about walking in public or exercise in public? How do you feel about eating? So exploring the feelings really help, because never teach people who are in pre-contemplation, because typically when we start to teach them, give them information, they never come back because they know what to do. Everybody knows what to do. It's just a matter of getting people to think what they can do about it. In a second stage, and typically it takes about 2 to 3 months to go from a stage of pre-contemplation to contemplation to the next stage. Preparation would be okay. What do I do now? So imagine you're being physicians, and then you see a patient in January, and then really when it comes to the actual doing, where we're creating the habits and so on, it will take a few months to get them from one stage to another. And number 4 is action, and 5 is maintenance, and there's also 6, which is after maintenance, people have a tendency, just like with smoking and everything else, go back to the older behaviors to where they are. So in conclusion, the best way to look at the metabolic health is metabolic health is not built in a moment. It takes time. It is shaped by small daily choices. We support, design, and empower. The key is to activate the patient and then empower them on an ongoing basis through their journey. And its health is not about perfection. It's about alignment, awareness, and sustainable change. And we don't improve metabolic health by telling people what to do and how to do it, but we improve it by building systems that make better choices possible. So finally, when we move from information through transformation, we just don't treat the disease, we change people's lives. And that's really the key. It's about improving it for better. So then the better state of being will create a sustainability of the whole environment, because if the one person becomes healthier, the whole family becomes healthier, and then the whole community becomes healthier. And that's really the exciting part of metabolic health.
Great.
Wonderful. So, do we want to take the questions right away, or just after second talk?
I think if Barbara wants to move or she wants to leave, then we can have a few questions now. What is comfortable for you?
It's up to you.
Okay.
Whatever works for you best. I'm fine with that.
So better we can take the questions after two talks together. So it would be better, I feel.
Great.
Right. So now we'll start the second talk from Dr. Madhu, who is Dr. Madhu Pandey. She is consultant endocrinologist from Norwich International Hospital and Medicare Hospital. She is MBBS and MD endocrinology, and her affiliation is with, she is executive member of DEAN, that is DEAN, and member of Simon. She has research interest in diabetes and metabolic disorders, thyroid and autoimmune disorders, and endocrine oncology. This is very interesting, and clinical endocrinology. So over to you, Dr. Madhu, for your talk on the thyroid connection and managing dysfunction and their impact on metabolic stability. Over to you, Madhu.
Thank you, Dr. Rutul, for this kind introductions, and thank you, Dr. Bansi sir, for providing me this opportunity. And today I'm going to present you the topic thyroid connections. So I would like to share my slides with you.
Yes, please.
Yeah.
Please share it.
Is it uploaded? I don't know, actually.
No, it's
I'm
not.
not so much
You can share it from your side, if it is okay.
They're asking for me for the password. I don't know how to do this.
No. There is a share, green button is there right at the bottom.
Right at the bottom, it is share. You can share it from there only.
First you click.
From Zoom?
Yes, Zoom.
You're on this platform only, you just click that. There is a share.
Okay.
Or you just Alt and plus S if you want to do that.
You can see the share. Is it there?
Actually,
at the bottom side?
Where, right or left?
Madhu, right at the bottom. What I am doing is just see your WhatsApp. Yes.
Yes.
Got it?
Now make it full screen.
Full screen.
Yes.
Okay.
Good.
So
now you can present your. Thank you. I think still it is not
thank
full.
you.
Thank you.
Dr. Bansi sir, for providing me this opportunity. And today I'm going to talk about the thyroid connection and managing dysfunctions and their impact on metabolic stability. So as we know, thyroid is a gland that plays a very crucial role in regulating the metabolism, energy balance, and physiological process in the body. So when we talk about the thyroid functions in my clinic every day, I come across with lots of different kind of patients who ask me, why do I need the treatment? My thyroid function is okay. My thyroid function is borderline. Do I need any treatment? I don't have any symptoms. So there are lots of things that I need to share with you as a clinician and as a endocrinologist that I want to highlight. So today we are going to briefly talk about the physiological of the thyroid gland, and we are going to talk about the thyroid disorder, the common thyroid disorder that we encounter in our clinic, and the metabolic effects and the diagnostic approach and the current management strategies. So can I do this a little bit down so that I can see clearly? So nearly 200 million people worldwide suffer from thyroid disorder, with a growing number of due to autoimmunity, as it regulates the metabolism, cardiac functions, and influences peripheral vascular disease health. So nearly 20 to 80% of cardiovascular mortality risk is associated with thyroid dysfunction, along with the comorbidities such as hypertension and diabetes. So what happened? Coming to the introduction, it increases the risk of CVD, including the heart failure, coronary artery disease, and AFib by impairing the heart contractility, stroke volume, heart rate, peripheral vascular resistance, and electrical activity. It alters the cardiovascular risk factors such as atherosclerosis, hypertension, and dyslipidemia. And antiarrhythmic drugs known as amiodarone also may induce thyrotoxicosis and hypothyroidism. So, seeing the physiology of thyroid gland, as we know, thyroid gland produces the T3, T4 hormone, which is regulated by hypothalamic pituitary axis, and TRH, which is produced by the hypothalamus, stimulates the anterior pituitary gland to release the thyroid stimulating hormone. In response to TSS, the thyroid gland regenerates the T4 and T3 hormone, which has the negative feedback loop, and changes in the T3 and T4 provides the clinical output in the hypothalamus and pituitary gland, which regulates the thyroid releasing hormone and thyroid hormone synthesis, as we know that. And although we know this, and T4 is the most abundant form of hormone produced by the thyroid gland, but still T3 is the most physiologically active hormone and mostly synthesized peripheral by the DID nodes. So whenever we see the T3 level is always there, but if we want to see the overt hypothyroidism, we need to check the T4 level. So major thyroid disorders that we encounter, when we see the TSH is decreased, we see it hyperthyroidism, and when it is increased, it is a hypothyroidism. We all know that. And but if the patient has high FT4 level, that is overt hypothyroidism, and if they have low level, that is overt hypothyroidism. So there is also one term called non-thyroid illness syndrome, or euthyroid sick syndrome, which there is a decline in the both total and free T3 levels, while level of T4 and TSH in the blood remains within the reference range, and there is a reverse T3 level increased. So we have major metabolic impacts on the thyroid disease. So thyroid disorder affects metabolic clinical parameters such as blood pressure, glucose, and lipid metabolism, and cardioendothelial function, suggesting a link between the thyroid disorder and the metabolic syndrome. So we know the metabolic syndrome has the three or more of the following, like abdominal obesity, arthrogenic dyslipidemia, elevated blood pressure, and insulin resistant. So patient with hypothyroidism always have this abdominal obesity and dyslipidemia, leading to the insulin resistance. So patient could come with the diabetes along with the hypothyroidism and some cardiovascular disease. So moreover, hypothyroidism increases the mortality rate in people with CVD due to impairment of myocardial contractility. So people with LT3S and hyperthyroidism had a greater risk of AFib and angina due to coronary artery spasm. So looking at these pictures, I want to see what are the cardiometabolic risks. So with the hypothyroidism, we have the atherosclerosis and hypertensions and increased SDL and coronary artery disease. So the mechanism, we can see hypothyroidism and atherosclerosis, which raised LDL and triglyceride, promotes the vascular damage. And with the increased LDL, there is reduced lipoprotein activity, and LT4 may normalize the lipid level, which treat the patients with thyroid hormone. And it can affect the endothelial dysfunctions and arterial stiffness, leading to increased cardiovascular risk. Hyperthyroidism has 2 to 3-fold risk of atrial fibrillations. Thyroid hormone always accelerates the heart rate, raising the stroke risk, and it could lead to heart failure and stroke. So both has the 20 to 80% of CV mortality rate. So again, we can see the hypothyroidism patient has the insulin resistant, while as hyperthyroidism has the hyperinsulinemic state, and patient with the hypothyroidism have hypothyroid myopathy. Whereas in hyperthyroidism, we can see the patient has muscle breakdown, they have loss of muscle mass, and patient with hypothyroidism, there is a lipolysis and increased cholesterol level, there is obesity, patient has bradycardia, hypertensions, and there is arthroma and stiffened blood vessels. We can see with the hypothyroidism. Whereas in hyperthyroidism, there is a risk of atrial fibrillation. There is always tachycardia. Patient with has elevated cardiac contractility, and so we can see there is a endothelial dysfunctions and decreased vascular resistance. And coming to the subclinical hypothyroidism, we encountered lots of subclinical thyroid disorder in our clinic. So it is a most silent contributor to metabolic risk. So which will increase the dyslipidemia, vascular dysfunction is rearranged, and cardiac complications are there. And as we know, lipid alterations with increased triglyceride and LDL level increases, which will promote the atherosclerosis. And there is a vascular impairment also that will lead to arterial stiffness and highlighting the risk of hypertension and coronary artery disease. And coming to the hyperthyroidism, it disrupts the cardiac rhythm and functions. And as we already told, it increases the 2 to 3-fold of atrial fibrillation, leading toward the stroke risk. Excess thyroid hormone also accelerates the heart rate and left ventricular hypertrophy. So we need to access the patient coming with the accelerating heart rate and left ventricular hypertrophy. We need to access, if the patient has hyperthyroidism, we need to treat that. So older patients with subclinical hyperthyroidism, we often encounter older patients with subclinical hyperthyroidism. And so in that case, whether we need to treat or not, so we are going to talk further about that. And we can see the cardiovascular system that is affected with the thyroid hormone. So there is a two pathway. There is a genomic pathway and non-genomic pathway. So genomic pathway mostly affects the heart, and which will increase the cardiac muscles, and there is a heavy chains and increased vascular contractility, and there is a increased beta adrenergic signaling, and there we can see the electrophysiological activity that will affect the ECG changes. And for the non-genomic pathway, we can say there is a cardioprotective actions, metabolic effects, renal effects, and direct effects on coronary artery disease also, as we already talked about it. So there are some considerations that need to be discussed and talked actually. So we have a different kind of thyroid disease coming to our clinic. And so first I want to talk about the subclinical hypothyroidism. Whenever there is an increased TSH with normal T4, then we call it subclinical hypothyroidism. So when to treat this? If the patient has normal TSH upper limit, that is a 4 to 5, and for that patient, we need to make sure the lower cutoff point is 2.5. And if it is above, if it is lower than that, then it is always a over treatment. So we need to consider these treatment accordingly. So if the patient has a natural history and patient has a 50% increase of TSH 4 to 6, and that patient mostly resolved in within 50%. So there is a risk of progressions there is a risk of progression definitely there. So overt hypothyroidism is going to be there. So we need to evaluate that patient every 6 weekly until it is normal. So if TSH is increased, we can check the FT4, and if FT4 is decreased, then it is a overt hypothyroidism, and then we need to treat. So if the patient with the normal FT4, that is a subclinical hypothyroidism, then we need to check the antibody. And if the TSH is greater than 10, then we need to treat definitely. And if the patient has less than TSH 10, then we can treat if the patient has symptoms, goiter, antibody is positive, family history has autoimmune disease, if the patient is planning for pregnancy, if the patient has heart failure, has cardiovascular disease, and for these patients, we need to monitor if untreated annually and watch for the complications, just metabolic syndromes and cardiovascular disease, if the patient has stroke, dyslipidemia, and pregnancy risk. So these are the things that we need to know. And for the coming to the hyperthyroidism is always a difficult part actually for our clinical practice. Patient sometime comes with the TSH 0.1 to 0.4. In that case, so usually what I do is I don't treat until I do the thyroid scan. So once I do the thyroid scan, then I think it's a autoimmune, it is a thyroiditis, or it is resolving thyroiditis, or it is just subacute thyroiditis. So in that case, we can manage accordingly. And for the patient with TSH less than 0.1, then that is a type 2 subclinical hyperthyroidism. So according to American Thyroid Association's patient age less than 65, we can monitor the thyroid functions every 6 to 12 months and treat if TSH is less than 0.1. And if the patient has symptoms, persistent elevation of thyrotropin receptor antibody titer, if the patient has fibrillations and osteoporosis. So for these patients, we can treat accordingly. And if the patient is older, more than 65 years with comorbidities, require treatment due to increased risk of cardiovascular and osteoporosis. So for the patient with subclinical hyperthyroidism, we can recheck the TSS level every 3 to 6 months to confirm the persistence of subclinical hyperthyroidism. Subclinical hyperthyroidism could be self-limiting, as we talked, because of virus, because of transient thyroiditis. It could be because of hypothalamic or pituitary stimulations. It could be exogenous iatrogenic thyroiditis, Graves' disease, nodular goiter, and cancer, and even the ablation therapy also. So hyperthyroidism treatment modalities for hyperthyroidism depends on the underlying etiology. So hyperthyroidism, which has the options, antithyroid drugs, carmiprazole, methimazole. We have the radioiodine therapy and surgery. And for the management, we can see the patient with CVD are started with low dose of LT4, diuretics, and beta blocker, and we can follow up every 10 to 12 weeks. For the beta blockers, can be recommended for the patient with AFib and supraventricular tachycardia to control the heart rate. And for the administration of antithyroid medications, we can add potassium iodide via oral route or sodium iodide via IV route, which can suppress the release of pre-existing thyroid hormone reserve. For the patient who cannot tolerate antithyroid medications, we can go for the radioiodine therapy, or thyroidectomy is the ideal treatment. For the patient with LT4 known for its socioeconomical and effective drug for hypothyroidism, it is used to achieve euthyroid state without increasing the peripheral vascular resistance, but it can improve the myocardial perfusions. So my take-home messages are, so as a thyroid gland play an important role in regulating metabolism and energy balance, the asymptomatic nature of this condition often delays the diagnosis. So routine TSH screening is not universally available, but it should be done wherever it is available. Treatment remains debated as managing disorder is complex due to their variable risk profiles. It is a silent contributor for metabolic disease, subclinical thyroid disorder, warrants increased attentions, and targeted TSH screening in high-risk groups such as those with dyslipidemia and arrhythmia could facilitate early interventions. So clinical and public health strategies should prioritize the awareness, research into optical treatment threshold to reduce the cardiovascular and metabolic risk, and early detection to prevent the silent cardiac complications. And understanding the thyroid metabolism connection is the key to improve the patient outcome, and appropriate treatment and regular monitoring can restore the metabolic balance and prevent the complications. Thank you. Hope you had the lightheadedness.
So you
Madhu,
can
I just want to ask you, rather it's a comment or you can say question. But most of the female who come and they have even subclinical hypothyroidism or even they have frank thyroid problem and they are
Yes,
on
sir.
medicine. So their first question is there, my weight is more or metabolically I am unhealthy because of my thyroid problem. And that to explain them is really very difficult. I mean, we explain them now you are on thyroid replacement, your thyroid function is now fine. It should not be the reason for you for not losing your weight or not for doing exercise or any medicine. And second problem is now with the Ozempic and then the news with medullary thyroid carcinoma correlation. A person with hypothyroid or even family history of hypothyroid, the first thing they are going to ask, can I take it? I have a thyroid problem because it has got some issues related to thyroid. I know at present, I don't know whether Ozempic or Wegovy is available in Nepal or not, but this is common challenge which we have. Purvi is there now with us. Purvi will have a lot of comments and questions. Thank you, Purvi, for joining.
And thank you for such a nice question, sir. Actually, lots of people come to my clinic and then they ask me, my thyroid function is normal, but still I'm gaining weight. Then I ask you, how do you eat? What is your diet pattern? Do you exercise or not? So there are lots of risk factors. Do you eat junk? Most of the people who have hypothyroidism, I don't know, they are having lots of junk food. So I usually tell them and make them feel that you are having lots of junk. So you need to avoid all that. Even I have hypothyroidism. That means I am not obese. So I give example of myself.
Okay. We have with us Barbara. Barbara, can you? She's there.
Barbara, are you there?
I think she had just shown the face. But one of the slide which Barbara had shown, there are 42 different other factors which are responsible for, sugar to remain uncontrolled or to have a glycemic variability. Even she's a registered dietitian and she had shown dietary factors which are important. But other than that, there are multiple such factors which are responsible for your glucose to go up and down. That's very important educational, whenever we talk to our patient, we must explain them it's not only the diet or food which is responsible. Because now a lot of patients to whom we put on continuous glucose monitoring, they keep on asking, that I have not taken anything else. My food is same. I'm eating the same amount of carbs. But still, my sugar is up and down. So I mean, it becomes easier for us if we explain them. And this happens more with type 1. And that's the reason we put them on AID. Why I want to put the patient on automated insulin delivery device, that I explain that it's not only your food which is responsible. Sometimes your middle of the night, one night your sugar is up, other night sugar is low. Now I can't increase neither basal insulin more or less. And they are the right candidate for putting them on a automated insulin delivery system. What, Purvi, what is your opinion on this?
Absolutely. I think well said. Definitely. I mean, I just think that these discussions are important because there is the guidelines and then there is the ground reality. And then there is a bridge in the middle that we are trying to fill. So I think well said, Dr. Banshi, sir. Agree with that. And I think Dr. Madhu also answered her question well. I think there was one more question
We,
in the chat box with respect
yeah,
to the
it is.
diet.
Yeah, it is foods to avoid in thyroid disorder.
Yes.
Okay. So
Interesting
actually, there
question.
is no any research done on cabbage, and mostly people want to ask about the cabbage actually. So they think cabbage and broccoli and coli has the uh, bad
But then how this
thyrotoxic.
myth had come, that each and
It's
every
all
patient
myth.
of us
People
knows
ask,
that
but
broccoli and
still they want to
cabbage is
hear
not
from
to
the
be taken. And no
doctors.
dietitian and no doctor is saying that it has nothing to do with this. So how this
Yeah,
myth has
exactly.
gone so, and it had become so
Viral.
popular that each and every
Yeah.
patient comes to you and he said the same thing.
Banda khana hai ki nahi? They just come and ask us.
Yes.
Yeah.
True. So, and
But do
this
you
also in
recommend any
very,
specific dietary recommendation is there for thyroid disorder?
So for the thyroid disease, I usually ask them to eat lots of antioxidant food. Maybe that will help you resolve the autoimmunity because if there is any autoimmunity, definitely antioxidant food will help you to relieve with that. Sometimes it resolves spontaneously, right? Because lots of autoimmune disease come and go, because lots of viral infections come and go. So if the patient has subclinical thyroiditis, yeah, viral thyroiditis, then maybe they will have lots of antioxidant and thyroid dysfunction could also go away. This is my personal opinion, actually.
So, Madhu, how about the thyroid disorder in Nepal? Because originally, when long back Kochipilli had done work, and which was, I know, great work which was done by him, the thyroid disorder was very high in our country in hilly areas. And it was
Yeah,
because of iodine deficiency.
iodine deficiency,
And then
right?
iodized salt was introduced in India,
interesting.
and iodine deficiency was one area which he worked very high. AIMS past professor of All India Institute of Medical Science. And then it's almost like we don't see so commonly the goiter because
Goiter.
of iodine deficiency. So what about in Nepal? Do you find still it is high?
So in Nepal also actually in our clinic nearly 70 to 80% comes with a thyroid disorder. So
But it is
subclinical
Hashimoto,
yeah.
or is
Mostly
it autoimmune
subclinical
thyroiditis?
hypothyroidism,
Subclinical.
subclinical hypothyroidism, not the overt or autoimmune. Mostly they come with the subclinical hypothyroidism. So, but the iodine deficiency goiter, there are very few patients who comes from the
Now it
Himalayan
is
region
less.
or from the far eastern zone. So from these part, we definitely see lots of goiter, but mostly there are non-functioning goiters. There is only goiter. There is no any thyroid issues or hormonal abnormalities in them.
How common you see thyroid carcinoma?
Carcinoma, sir, maybe once, 3 or 4 patients in a month, not more than that.
But how you suspect?
But
So
that's
mostly
quite
they don't have any clinical symptoms. So they come and just come and usually mostly it is incidental. I just do the examination of thyroid to the every patient, even they have diabetes or anything. I do the examination. Whenever I find suspicious of any nodule or anything, then I do advise the ultrasound of neck rather, and then we do the thyroid function test and thyroid and antibody. We do all the package thing, and most of the patient have less than 1 centimeters of thyroid nodule. So and for that patient also we can see lots of papillary thyroid carcinoma, sir.
So
Not
FNSC,
1.5.
FNSC and thyroglobulin is a tumor marker. How often you ask?
So once it is diagnosed, then we do advise for the thyroglobulin and thyroglobulin antibody. And for the later on screening for the PTCA, we do frequent test after holding the thyroid norm for few days until TSH is high, and then we do the thyroid scan. We have that facilities nowadays. It's very easy for us to do the thyroid scanning and whole body radioiodine scan. So that has helped us a lot.
Nepal is T3 is available. We do
Mm,
use here in T3.
yeah, we have, but we don't use that much, sir.
We don't use them. But it is available in your country?
Yeah, actually, that Abort company has launched, but not freely available. Sometimes it's available, sometimes it's not.
Okay.
So because
Is
you're not
Manilka is
using it.
there? Or Barbara, are you there?
No.
sir. I
Hi,
I
have
am
a
Dr.
here.
Ruby.
Very
question.
sorry. I'm here. I had to
Sorry.
turn off because I lost the connection for a while.
Okay.
Yeah.
So one of your slide which we liked very much, that you had shown the Kelly close concern. I think they had put the slide. The slide was showing the multiple factors which are responsible for glycemic variability other than the food, which is 42 factors, I think you have shown.
Yes.
And
that's
so
publicly available, and you can use it. I put the reference of it.
Yes. So what I want to ask you, in India, I don't know whether you know about the Indian food and Indian cuisine, but they have a lot of carbs in their diet. And if you see Southeast Asia completely, whether you go to Nepal or Sri Lanka or Mauritius or Maldives, everywhere you will find a lot of carbs, and food variety is also very different. And we use everyday different variety of food with a lot of carbs. While American diet is, or you can say the Western diet is more or less it is same. Now, still it is increasing in the carb content also, but they have more of a meat or more of a protein in their diet. So the glycemic variability which we find is much more in compared to the person who is Caucasians or who is taking the diet which is more or less same type of food on every day. There is a the salad, whatever the food is they have. While in India, we have a lot of this glycemic variability. That's our personal clinical experience. And when we put the patient on continuous glucose monitoring, then it becomes, again, you can see it. And so we use here more acarbose, that is a alpha glucosidase inhibitor, which is normally not used neither by any Western country or nor in US. Even it is not even guideline. American Diabetic Association had discontinued it in guideline also. Even it is a drug which was produced by a German company Bayer. All over the world they are producing, and the highest sale of this drug is in China and in India only. So Glucobay is the brand for that. And even the PPC guideline which we have written from IDF, which we are writing again, post-meal glucose control. So how you deal with this post-meal uncontrolled diabetes and glycemic variability? Is it only by diet, or do you recommend that no, something more to be given to these patients?
So first, you said it right, Dr. Sabu. It's really using CGM to identify, because it varies. There's two very different variables and different contribution to it, and then medications. It's there is some medications, as you know, the mealtime ones, or the other ones. It's sometimes it is pathophysiology that is contributing to it. It's not just food, and then also combination of food can help, but medication, number one, monitoring the blood glucose and then figure out what it is, and then the thing with the nutrition is not very reliable science, because it's very there's so many variables that goes in it. So there's no one human being that the body responds to food. There's people who can eat just carbohydrates and they're not going to have a spike. So with Southeastern Asia, it is really more of a not just population at this moment. It's just the same thing as we have in US. It's very individualized. You gotta see how their body responds to it, and then if nutrition cannot be manipulated, then medication.
Great. So, Barbara, I also have one question. How do you rate intermittent fasting, and how commonly you prescribe, and how you manage it then? So, and for how long we can continue intermittent fasting?
So the good news is South Asia is very good about intermittent fasting. The population has done it for hundreds of years. So and there is a great science to it. So we're learning from you guys at this moment. And so there is a strong evidence, with it could be done once a week, like every fifth day. It could be 36 hours. So it could be 16. But typically what we are seeing that the most cardiometabolic friendly one, especially for women, and with menopause or premenopause, postmenopause, is the 16-hour one. Because then if you do it for too long, after 16 hours, then the body turns into the starvation mode. And for women who are like menopausal, that is not a good thing. So it has to be individualized, but if I were to come up with the one safest one, it would be the 16-hour one. for most of the women. But of course, there is also Ramadan. So Ramadan works in that way, once a week, every fifth. So it really kind of what works culturally for people and within the culture, and what is their meaning? Is it spiritual or is it for health? So it will. I'm sorry to my every single answer is going to be individualized. So it really
Barbara,
depends
which will be the best? Do we have any review
on the
article?
individual.
But do we have a review article to show that which one is the best? If someone is doing fasting from 10 to 6, I mean, in morning, he first time eating at 10 o'clock and last meal of the day is at 6 o'clock, and that's a 16-hour fast. Or someone is doing on every Tuesday, or someone is doing on every 15th day, or someone is doing like Ramadan, or someone is doing for 36-hour fast. So do we have any data to support that which one is better? Because there is an intermittent fasting. People have also done that first meal they are taking at 2 o'clock. So I mean, completely avoiding morning breakfast and taking late lunch, and then to eat till late night, maybe by 10 o'clock, because they can't leave that time of dinner. So the 2 to 10, and still they are doing fasting of 16 hours. Is it
And
good?
very much relevant for our Indian
Because
doctors,
that's very important,
especially.
because there are people who are getting up at 10 o'clock, 11 o'clock, and then they want to do late lunch or brunch, whatever you call it, at 2 o'clock, and then they want to eat till late night, and then again they are saying that we are doing 16-hour fast. I mean, is it we have data for that tools?
I don't know. We're going to have more on intermittent fasting from ADA coming out in the nutrition consensus this year. The data that has been presented at the scientific sessions, so it's really population based. So I don't know for your Southeast Asia if there is any specific data that is applicable to your population. But I know that there are some studies with measuring the length of intermittent fasting on different populations, but I'm sorry, I'm not very familiar with that data. We can look it up. We can definitely look into it.
One more and very challenging for us is to give more protein to our people with diabetes. I mean, we know that diabetics, they develop more of sarcopenia, they develop muscle weakness over a period of time, and whatever the medication which we are giving to them, whether SGLT2 or GLP-1, that further reduces their muscle mass or lean mass. So, and then to give them up to 1 milligram per kg, and that too for vegetarian people who are in Southeast Asia more, and particularly like from the state, from me and Rutul are there, Gujarat, where many of our people are pure vegetarian. So how to manage their protein intake to maintain that 1 milligram per kg? I mean, what are the different foods which we can give them, which is vegetarian? Source of those things should be vegetarian.
Yes. So as you were speaking, I was with the protein situation, got me thinking about the time, the previous question about the timing of the intermittent fasting and what to do about it. A very good thing to consider for intermittent fasting for people who fast and then they overeat and then they GLP-1s. GLP-1s is really the way to do it. There is a really good data coming from that because remember, the food noise is going to be physiological, so that you cannot fight it with your brain. So the GLP-1, to answer your first one, I would go with that as a clinical approach for any form of intermittent fasting. It's the safest way to do it. And to answer the protein situation, it's just as simple as that, is making sure that whatever we're eating, even if it's a snack, has a protein in it. So I just went to the Indian restaurant. I go once a month, and I always make sure that I got my beans in there. I got the cottage cheese square in it. So it's just making sure that even if it's breakfast, even if they eat a snack and it happens to be a fruit, ask them what's your protein. And then the most important protein is at nighttime. What people do is they go high with their carbs and not enough protein. And when I say enough protein for the meal, it should be at least 21 grams of protein per meal. And for snack, it should be at least 14. So we call one serving of protein 7 grams of protein. So 14 per snack, at least 21, which is like a deck of carbs for meat, of protein.
It is
and
dream for
at
me.
nighttime.
I mean, for myself, for my diet also, it is dream for me to have 21 gram in every meal. I don't know, Rutul might be taking, but I don't know. Yes, Purvi?
No.
So,
I shouldn't take it.
with respect to intermittent fasting, there was a systematic review that was published last year, and clearly it shows that, alternate day fasting seems to be the most effective regimen of intermittent fasting rather than fasting just once a week, or even time restricted eating, which means that, 16 hours window or 12 hours window, and then the remaining hours you can eat. So the most effective one has been seen to be alternate day fasting, which is responsible for at least 5 to 10% of weight loss, baseline body weight loss. But even time restricted eating has a lot of other benefits besides modest weight loss, even reducing, total fat mass and other metabolic control, overall improves.
Sure. Completely makes sense. And that was done for the population for the Southeast Asia, the every
No,
other day.
this is actually global data. They had considered 99 trials and more than 6,000 patients. The only limitation, or one of the biggest limitation found, was that these were short-term studies. So it is difficult to find longer term studies and make sense of
Yes.
it. This is up to 24 weeks, and that's not enough when it's a dietary intervention that's being evaluated.
Yeah, it's tough because we had one of the sessions in scientific session, I think last year, or maybe 2 years ago, we got the debate happening. So the studies, there's always a one or two side of a story. That's why I was talking about the 16-hour one, because the big debate right now is the women during the menopause and pre and post menopause, which one is the effective one, and we're still trying to figure it out. But thank you for saying that. I'm going to look into that paper.
We have to thank Dr. Banji sir for bringing up that very, very interesting and pertinent question.
You.
It is. Yeah, I think that it would take us a while to figure it out.
Purvi is very, very active member of International Diabetic Federation Women Group. We have created internationally, and she is currently secretary and working with very closely with Dr. Noor from Oman. So, and a lot of
Nice
work she
meeting
is
you.
doing for our Indian Obesity Society, our RSSGI, Diabetes India. It's great.
Fantastic. Yeah.
I'm grateful to have mentors like Dr. Banji sir.
Oh, no.
And very engaged colleagues like Dr. Rutul.
Thank you.
Now, what's nice about working with physicians like you is we are a multidisciplinary approach. So, like,
So
as a
Barbara,
dietitian, we cannot do it without you.
PSG group is constantly asking me for our follow-up. So I will be writing you mail to again, and we will connect you for Diabetes Asia for once more. And Rutul, can we close now?
Yes, we
So please
are
propose
more
vote
about
of
the
thanks
time.
and we can stop. Thank you.
So thank you again, everyone, for being here. Dr. Manilka could not be here as he was busy in OPD, right in between OPD. So on behalf of IDF Southeast Asia Women's Group, I thank you everyone for being here and patient listening. It was really a wonderful talk by Barbara and Dr. Madhu. Both the talks were different talks what we usually listen, and mainly we nowadays talk about GLP-1 and only obesity, but this was completely a different talk. So thank you very much, both the speakers and my chairperson, co-chairperson, Dr. Manilka, and thank you very much, Bansi sir and Dr. Purvi Chawla, for being here and inspiring us. Thank you.
Thank you.
And
Thank
good
you.
night for
Everybody.
Southeast
Thank you
Asia.
so
Good night.
much.
Good day for
morning to
you,
you,
Barbara,
Barbara.
and thank you, Madhu. Thank you.
Thank you,
Thank
sir.
you. Bye,
Bye.
everybody.
Good night.
Thank
Bye.
you so much. Good evening.